already said thank you to the sponsors, but at least in a silent internal moment, say thank you to the sponsors again, because that was, I thought, pretty good food. All right. I don't think that was silent and internal, but I'm sure it's appreciated. I didn't realize we would already have somebody identifying the lemur carcinogenesis stuff before I got started, but we will touch on the lemurs as well. I wanted to talk about about the spontaneous neoplasia that we recognize from a diagnostic standpoint. So there's not a great deal, if any, research-related stuff. These are all going to be spontaneous tumors. So essentially, when we think about neoplasia of the liver, there are three major categories, which would be obviously hepatocellular, biliary, and then others. And so hepatocellular adenoma, cholangiocellular adenoma or biliary adenoma, hepatocellular carcinoma, cholangiocellular carcinoma, or biliary carcinoma are the ones that I think are the building blocks of what we expect to see and the majority of what we do see. But one thing to keep in mind is that we look at if we look at neoplasia as a whole in veterinary medicine, in dogs in particular, primary hepatocellular neoplasms, hang on, maybe I need another cup of coffee. Primary neoplasms derived from residents of the liver constitute about 1% of total neoplasms. So these are not very common things. And I attempt to make the point with the second-year students that if they see multiple lumps in the liver, they should not think of primary neoplasia as their first thought. They should think of metastatic lesions, and then depending on what else they find, they may whittle it down to primary. It sinks in with a certain proportion, but not everybody. And then there are mixed hepatocellular and cholangiocellular carcinomas. They're not very common, but they certainly do occur. And then of the major others would be hemangiosarcoma, which it's pretty tough to prove it's a primary hepatic hemangiosarcoma without a very thorough postmortem. And you've got to skin the dog too because of the subcutaneous hemangiosarcs. Carcinoids, which we'll talk about in a little bit of detail. Hepatoblastoma, which is pretty much limited to foals in rodents. And then myelolipoma, which can occur. And then there's a couple others. And there's a variant down here. It's called scurus hepatocellular carcinoma, which is a relatively new term to me. And it comes from some work from the group in the Netherlands. And we'll talk about that briefly as well. Is it really raining, or what does that sound? Oh, it's air conditioning. Okay. I spent too much time in California. When I suddenly hear a vague rumbling, it makes me a little twitchy. So we're talking about the basic proliferative lesions. We'll start with the non-neoplastic proliferative lesions. Nodular hyperplasia should not be something new or surprising to you. It's age-related. Right around 6 years of age, dogs start to develop nodular hyperplasia. By about 10 to 11, essentially every dog has some evidence of nodular hyperplasia. They can be yellow masses because of lipid or glycogen. They can be dark red because of increased blood. So there's a range of colors that they can have. They're usually quite discrete. The background of the liver is otherwise normal. And essentially, the lobular architecture is retained. The portal tracts may get moved around a little bit, but you can still find portal tracts scattered through that lesion, which is one way to distinguish it from regenerative nodules. The other way is regenerative nodules usually arise on a background of significant liver injury. There's got to be some drive for regeneration, and they typically have usually only one portal tract there. They're of no clinical significance, except when I'm talking to the students. You do not want to euthanize a dog because you've decided he's got hepatocellular, he's got hepatic metastasis because he's got 2 yellow lumps in his liver. So here are some examples. Here's a fairly subtle one. And of course, sometimes they're within the entire parenchyma and you need to slice through the liver to be able to find that. We call that bread slicing, not bread loafing. And here's another one which is a little bit almost pedunculated. So sometimes they're quite obvious. Sometimes they're relatively subtle. Both of these have more or less the same color as the liver. Here's a cut surface of one that's a little more, it's a little paler. and here's one that was definitely paler, and they typically have a very discrete interface with the adjacent liver. Now, when we're confronted with multiple nodules in the liver rather than solitary or maybe a couple, the two differentials or the major differentials you would think about in terms of non-neoplastic would be regenerative nodules. Again, nodular hyperplasia, it's usually only one or two. Or then metastasis, which is the most likely thing for multiple nodules. But then the carcinomas, biliary carcinoma, hepatocellular carcinoma, and carcinoids are another possibility. So here's an example of an end-stage liver with multiple regenerative nodules. And here's another one with multiple regenerative nodules that are much smaller. So sometimes they're big, sometimes they're small. There have been explanations in the past about which is which, but in veterinary medicine, I don't think there's a clear understanding. And then another multinodular lesion in the liver is what we see with hepatocutaneous disease. And typically the livers have this, looks more like a cluster of grapes, so a more uniform population. And then there's a typical change in the skin, usually in the foot pads, the scrotum around the face. And it's supposed to be the classic red, white, and blue. So there's hyperplasia of the basal layer, edema, and then hyperkeratosis. But what's interesting about these lesions is that when you have these multiple nodules, you tend not to have fibrosis between the nodules, but rather areas of condensed stroma. Sometimes the nodules are vacuolated, and sometimes the damaged stroma in between is vacuolated. There's always almost some vacuolation associated with that. And that's in contrast with this liver that has multiple regenerative nodules, and this is a serious red stain. And so there's lots of collagen in between these nodules, whereas with these others, it's not so much. All right, hepatocellular adenoma, they're usually solitary. They're common. They have a loss of trabecular architecture, so you don't have the normal placement of portal tracts in there. The trabeculae tend to be uniform, and by that I mean they don't change thickness radically over a short length of time. As a resident, I spent 20 minutes at a time counting how many cells there were in the trabeculae, and I said, oh, more than 4, it's a carcinoma. I no longer subscribe to that school of thought. So I think if the trabeculae are relatively uniform, I don't make my call on the basis of the thickness of the trabeculae. I'll come back to this in some more detail when we talk about carcinomas. I think we have been over-calling primary hepatocellular tumors as carcinomas since the dawn of time. If you want to look at the number of dogs that you have encountered that have died because of metastasis of hepatocellular carcinoma, raise your hand indicating the number of cases you've seen. That's the same number I've seen. So you can find metastasis. You can find tumor in the hepatic node. You can find tumor in the lung. I'll show you another interesting one in just a second. But essentially, no dog dies from metastasis of hepatocellular tumors. What kills the dogs is necrosis and hemorrhage, and they bleed out, or the tumor gets necrotic and infected and they get septic. So I have mentioned to the residents that if they never even look at another tumor and just call them all benign and walk away, before they get caught up in one that's caused death because they misdiagnosis, they'll be retired. So I think we have to apply much more stringent criteria, this is personal opinion, not fact, on primary hepatocellular lesions. I think most of them are adenomas, and there are some carcinomas, and I'll show you some examples when we get there. So here's what I think is an adenoma. It's a single mass. In this case, it's paler. It has a reasonably well circumscribed border with the adjacent parenchyma, and they can get really big. One of the things you like to see for adenomas is, again, a nice discrete border. And this guy doesn't have a normal distribution of portal tracts like nodular hyperplasia would. Here's another example of that nice discrete border. And here's a zone of compression of the adjacent parenchyma. And those cells are undergoing atrophy and necrosis from pressure. And these trabeculae often tend to abut at almost right angles with the capsule. So hepatocellular carcinoma, I think they're uncommon in most domestic species. They tend to be friable, gray, yellow to red. There's often necrosis. And I'm going to tell you that metastasis is uncommon. There's an exception to that, which we'll get to in just a second. I've had the opportunity to write the same book chapter periodically, and the good news is no one looks at the previous edition to see how much I've changed what I said from one to the next. So I'd only read the most recent edition. Yeah.
When you refer to metastasis, are you talking about distant visceral metastasis?
Well, I'm primarily talking about metastasis outside of the liver. The intrahepatic metastasis is a little more of a can of worms. Without genetic assessment, it's hard to tell whether they're multiple primary spontaneous. The rodent path people are working on that, and I think they've often identified separate clones of cells, but those animals have been subjected to significant carcinogenic insult, whereas the dogs, we don't know what's going on. While we're on that subject though, everyone remembers there've been 1 or 2 outbreaks of aflatoxin contamination of diet and lots of dogs that died. I'm waiting for the wave of liver neoplasia to come because the dogs that didn't die from acute aflatoxicosis got a pretty good dose of aflatoxin. We know it's a carcinogen in people and rodents. Well, in rats, not so much mice. But I have not seen the flood of primary hepatocellular carcinoma 5 or 6 years after those outbreaks. So typically we have masses that are in multiple places, again speaking to intra-organ metastasis possibly. And there are a bunch of variants that I don't really know the value of making the subdivision. The trabecular, the glandular, the solid, the clear cell, because within an individual mass you might find all of those variants in a single tumor, and there is no prognostic difference between them. So if you are a dermatopathologist at heart, then you like making long lists and subdivisions with no particular meaning. But we do recognize these forms. They're usually mixed, and there's no relationship, and there's one exception, which we'll get to. So this is the take-home for hepatocellular carcinoma. As far as I'm concerned, these are the key features that I look for. I look for pleomorphic hepatocytes. Pleomorphism is important to me in making a call. Mitoses, if I can find, there is no cutoff. It's not like soft tissue sarcoma, 3 it's not, and 5 it is. But the more mitoses I see, the more concerned I get. I don't know if you've looked at a liver with cholestasis. The rate of mitosis in a normal liver with cholestasis is generally about 10 times higher than the rate of mitosis in any of the tumors I ever looked at. So there's not a direct correlation between mitosis and problem, but I think it gives you an indication of the rate of growth of the cell population. Invasion is very important. If you can find local invasion where instead of a nice capsule, you've got a finger tumor growing in the picture we saw of the fruit bat, there was an interface between the tumor and the normal, and there were like individual cells kind of poking their way into that adjacent parenchyma. I thought that was a very persuasive argument for malignancy. Occasionally you can find intravascular invasion with the cells, or of course isolated tumor populations in the cells. That is remarkably persuasive. And later we'll get to a little discussion about immunohistochemistry and cytokeratin 19. Cytokeratin 19 is a marker normally associated with immature or relatively mature bile ducts. And there's a subpopulation of hepatocellular tumors that start to express cytokeratin 19, and those are some bad actors. So those are the features that I think are important. So here's an example where you have trabeculae of varying, they're misshapen, they're odd, there's some pleomorphism, some are almost round, some are very thick, some are thin. If I see that, I'm good. Hepatocellular carcinoma. Here's another example where there's some areas of sort of regional depth filled with serum and some fibrin. Again, thick, variable size trabeculae. I think these kinds of things are strong indicators that you've got a malignant tumor. Here's a solid variant, and here we've got multinucleate cells, quite a bit of pleomorphism. This is the kind of thing that I look for, again, in terms of pleomorphism. I couldn't find any mitotic figures in this field, but you've got trinucleate cells and really big cells. I'm okay with carcinoma here. This is something I wish I'd never said. This is the clear cell hepatocellular carcinoma variant, and this matches the wallpaper from the text that preceded my involvement. I think most of these are probably adenomas because I don't see the pleomorphism. I tend not to see the invasion. I think they got stuck with the name of clear cell carcinoma because we never came up with the term with clear cell adenoma. But I think probably realistically they are likely, for the most part, adenomas. Now, if I can see these kinds of regions of invasion extending out into the adjacent parenchyma, and here we got irregular trabeculae plus this invasion, we're good. One thing that I used to think, I fixed this once, was important was necrosis. When I was in that WSAVA group, the other pathologists persuaded me that areas of necrosis were found in both adenomas and carcinomas, and it was not a useful marker. So I don't rely on necrosis, but I certainly rely on invasion. So if we want to look at the literature, can we predict the risk of metastasis in primary hepatocellular carcinoma? And I don't know if you're familiar with the literature, but the answer is you can have any answer you want. Reported frequency, 61% by Paddock in 1981. 61% of hepatocellular carcinomas metastasized according to this study. Most of them went to the hepatic lymph node. And how many dogs do you know that have died of metastasis to the hepatic lymph node? Not so many. But nonetheless, that was the report. In this paper, if you look at it, there are a series of supposed to be poorly differentiated hepatocellular tumors, most of which are the ones that meted. I think they are probably histiocytic sarcomas. We didn't have that diagnostic term. We didn't have the tools to identify it. So I don't think, I think part of the reason this number got so big is because there was another tumor type wrapped in. There was a study back in '82 by Trigo, 25%, and then there was another study in 2004, 4.8%. So I suspect that this is probably a more accurate number. When we had this little working group and we had all the pathologists who've been looking at liver for 10, 20, 15 years, and we tried to count up the number of dogs with metastasis we had seen, we could bring 2 to the table. And people sort of remembered some, but there weren't any more than that. So you had probably about 200 years of veterinary pathology looking, and we had metastasis in certainly less than 12 cases. So I think it's pretty uncommon. So having said that, there is a subdivision. I don't know if anyone is familiar with this work. It's back in 2013. At the ACVP meeting a couple of years ago, I had Renee von Sprundel come and present this work that she had done. She'd worked with Ted Vondening, who is the liver dude in Europe for the most part. And they did a study of hepatocellular tumors, and they used a series of markers, HepPAR1, which is an immunohistochemical marker that apparently stains some mitochondrial protein in hepatocytes. It stains hepatocytes and I think GI epithelial cells. Cytokeratin 7 and cytokeratin 19, which are markers for biliary epithelium. Glypican 3, which is a marker, as we'll see, for hepatocellular carcinoma. It comes from some human work. And MUC1, which is another surface marker on hepatocytes, and CD10. So the theory that this group has, and they've worked in sync with another human medical school hepatic pathology group, is that you can take a hepatic progenitor cell, which would be cytokeratin 19 positive, and those cells can undergo maturation to a mature hepatocyte, which is cytokeratin 19 negative, and that could give rise to a tumor that is cytokeratin negative, but hepatocellular carcinoma. You could have one of these progenitor cells morph into a mature cholangiocyte, and they would give rise to a cholangiocellular carcinoma. There's another little subdivision, which is a cholangiolar carcinoma, which there are very few of. But the concern here is they're positing that there is an intermediate cell that becomes a hepatocellular type, but still retains cytokeratin 19 staining. And I'll show you that in just a second. So it's this intermediate pathway that they think gives rise to the aggressive hepatocellular carcinomas. And so in their study, they stained nodular hyperplasia. There's our typical H&E appearance. There's a crisp line of demarcation. There's the normal hepatocytes. All those cells stain with Hep-Bar. They don't stain with CD10, and the only cytokeratin 19 is the biliary epithelium within the mass. And then they look at hepatocellular, and much to my frustration, they refer to them as hepatocellular tumors. They don't say adenoma or carcinoma, they just say tumor. So I'm just repeating what they've given us. So here's one, low risk of metastasis. The H&E has the pleomorphism we like to see, but they're all Hep-Bar positive. And then the cytokeratin 19, I'll skip over some of these other. Cytokeratin 19 only stains bile ducts and occasional individual cells, and MUC1 is negative. So these are low risk of metastasis. But these are a subset of tumors that they identified that were cytokeratin 19 positive in more than 15% of the surface area of the tumor, and the tumors were Hep-Bar negative. And they're also glypican positive, which I don't seem to have an image of right here. But roughly about 80% of these tumors metastasized when they had the cytokeratin 19 staining and the dropout of the Hep-Bar 1. So here's a quick table of what they came up with. So if we look at hepatocellular tumors that were K19 negative, they had 0 to less than 5% K19 expression. These guys were in the low grade, and they were all stage 0. They had never metastasized any place. They also had no glypican expression, and they had pretty much solid Hep-Bar expression. But the hepatocellular tumors that had the high risk of neoplasia, they're cytokeratin 19 positive, they were the ones that had meted, and they had essentially a very low cytokeratin 7. They had a lot of glypican expression and no Hep-Bar expression. So the take-home message is there was a subset of tumors that seemed to fit this intermediate stage that had cytokeratin 19 staining for at least 15 or more % of the surface area. And again, there's not a million of these cases, there's 4 of them. But they're the ones that had a very high rate of metastasis. I've never seen one of those, but that's what these guys have reported. We'll let that go. So take home, small subset of tumors stain with cytokeratin, more than, I think, should be 15% of the surface area, and glypican 3, and they don't stain with Hep-Bar 1, and these are the ones most likely to metastasize. And so I said to Ted, well, Ted, they don't stain with Hep-Bar 1, and they do stain with cytokeratin 19, and they have an aggressive behavior. Why aren't these biliary carcinomas? Because they don't stain with Hep-Bar 1, and they do stain with cytokeratin 19. And I don't know how many of you know Ted Bonzening, but Ted Bonzening said it's because they look like hepatocytes. And that was the end of the conversation with Ted. So I think they probably are intermediate cells, and whether the tumors that arise from intermediate cells. And if you want to see them as a hepatoid biliary carcinoma with typical biliary carcinoma behavior, or whether you want to see them as a hepatocellular tumor with some biliary features or intermediate features, I think it's a wash. But they do look like biliary hepatocellular epithelial cells under the microscope. So, having said that, some tumors with Hep-Bar do metastasize. So you're still in a little bit of a bind. This is a great case that came from one of the JAVMA What's Your Diagnoses? And so you'll recognize this is not part of the abdominal cavity. And here's a mass on the mandibular symphysis, or in the gingiva in front of the mandibular symphysis. And they're all Hep-Bar positive, and they have the features of malignancy. So there was a primary hepatocellular carcinoma that meted, here's the epithelium, to the gingiva. You won't see a lot of those, but just points out that they can be Hep-Bar positive and they can still met. And then, based on the features that we just went through, thick trabeculae, pleomorphism, mitotic figures, would you know what I'm setting you up, right? Would you judge this to be a benign or a malignant neoplasm based on its histologic features? If you're from NC State, you can't vote. I already showed you this. What do you think? Who sees malignancy here? All right, we'll vote. Who sees a malignant tumor here? Who sees a benign tumor here? Great, that's what I wanted you to do. Anybody know what that tissue is? Lung. So they do what they want. Sometimes the features are predictive. Sometimes the features are not predictive. Sometimes they're Hepar positive. Sometimes they're not Hepar positive. They just don't met very often. So when you write the report, you do not want to be definitive one way or the other, because you are armed with the knowledge that the phenotype does not necessarily predict behavior all the time, and the Hepar staining does not always guarantee that it's not going to met. And there's at least a subset that are these intermediate types, and they do have an aggressive behavior, but you have to know to stain them for cytokeratin 19. Otherwise, you won't know.
Dr. Cullen,
Yeah.
so you said, you said that you don't necessarily like the term hepatocellular tumor, but that may fit in the event it does metastasis and then you're covering your face.
Yeah, but that's the wimpy way out. So, and that's exactly what they took, which I was very annoyed with. I think you just have to take a stance. An adenoma, it's a carcinoma, and you can say, this is based on histologic criteria, I'm calling this a hepatocellular carcinoma. The risk of metastasis is very low. I would never want somebody to kill a dog because he has a hepatocellular carcinoma, particularly if it can be resected, because what kills them is necrosis and they bleed out. Now, the problem is talking about the intra-organ metastasis. If you got 3 lobes affected, then you got trouble. But again, and maybe you could infer that that really is intra-organ metastasis, and metastasis has taken that dog down. And I would accept that as an exception to what I'm saying. But for the most part, if you have a single tumor and you can resect it, there's a couple papers in the literature from the heroic surgeons who had hepatocellular carcinoma. They removed the lobe and the dog survived for another 4 years. A brilliant surgery. I think there are adenomas that they took off from a single lobe and the dog did fine, which is not too surprising. But there's an exception to all of these rules. So I would call them histologically adenoma, histologically carcinoma, and then I wouldn't worry too much about this if I were you. Yeah?
You mentioned that you don't factor fibrosis into distinguishing hepatocellular adenomas and hepatocellular carcinomas. Do you factor in, though, hemoabdomen as a result of intratumoral?
I think dogs with both kinds of tumors die from hemorrhage. So I don't think it makes a difference. But this is all what we call highly subjective. No marker lets me say this is a malignancy, this is not. Well, that's good to hear. Yes. Yep. I don't think so, but I don't think it says in the paper. I think they just graded and staged them. I don't think there was individual follow-up on those cases. But that may be a function of faulty recollection rather than lack of information. But if you look up von Sprindel and von Janine, you won't find too many. You'll find a couple papers. You find 3, but you'll be able to figure out which one's which. They actually did the hepatocellular tumor classification paper twice, which is pretty inventive, trying to build your CV. And then they have another one in cats, which we'll get to in just a second. And then occasionally you see things like this. This is omentum. And this dog had surgery for a mass in the liver, and then he came back with masses in the omentum. But I think benign neoplastic and malignant neoplastic hepatocytes, like spleen, can survive in the omentum. So if you shower the omentum with bits of tumor when you're removing the primary mass, you may see independently supported masses of hepatocytes in the omentum. And maybe it can happen spontaneously with rupture and release, but this was post-surgery. Now, in this case, there is some independence. This is the closest thing I ever had to metastasis in 33 years at NC State that I recognized. Okay, so what do we know about mixed hepatocellular cholangiocellular carcinoma? They're uncommon. Here you can see some ductular differentiation, and then it gets to be narrow ductular differentiation, and then you have a hepatocellular population. So you do see mixed cell populations. They're just not very common. The prognosis, there's so few of them, I don't know if there's any evidence they act more like biliary carcinomas than hepatocellular. I just don't know. And there was a nice, again, back to the bat carcinoma. You notice the bile between the hepatocytes in the hepatocellular carcinoma. You don't see bile in biliary carcinoma, you see mucus, but you do see bile in hepatocellular carcinoma. So this is an example where we've got some mucus in these. They look kind of like hepatocytes. This might be one of those intermediate ones if I bothered to stain it with cytokeratin 19, but this is before I knew about that. So this is a mixture of hepatocellular and biliary cells as well. Usually what I have done in the past is use cytokeratin 7 to indicate which are the biliary cells, but that doesn't map to the later study with the cytokeratin 19. Let's see. So there's another mixed one that has some ductular elements and some pleomorphic hepatocellular elements. And this is again cytokeratin 7 showing some of the ductular elements and other areas that are ductular but don't light up with the cytokeratin 7. So the mixed ones. I have no idea why that picture is so lousy. This is a mass on the side, obviously in the side of a liver, from a dog that one of our former residents sent us. And what was curious about this one is it had hepatocytes, but it had regions of fibrosis with ductular elements in it. And we get this large area of fibrosis, and within the fibrosis is cytokeratin 19 staining. In the literature and in the paper from von Sprundel, they talk about a scurus carcinoma, which is a term from human malignancies in which the hepatocellular carcinoma has abundant fibrosis, which makes it a firm tumor. But within those bundles of fibrosis are a number of ductular elements. So this was one case that had a fair amount of fibrosis, and within it there were a number of ductular elements, which then brings you to, is this a mixed tumor? Is this the so-called scurus tumor? Or in fact, in areas of hypoxia, you'll get ductular metaplasia from the hepatocytes. So I'm not sure which of the three these really represent. I think there's one purported scurus carcinoma in the veterinary literature, but you will see variants of the tumors that have large areas of fibrotic elements and then biliary or cytokeratin 7, cytokeratin 19 positive cells within them. In the paper from von Sprundel, they weren't finding ductular elements like this. They were finding regions within the tumor that looked like hepatocytes that were cytokeratin 19 positive. So there's a difference between what they're calling cytokeratin 19 positivity and these ductular elements. So it becomes a subdivision. And I think when we only have one or two examples of these things, it's good to be aware of them, but we don't have a real category yet for them to fit in that I think I can be confident or consistent about. So the same group, here we are, von Sprundel and von den Eng, did a classification of primary hepatic tumors in the cat. And they found metastasis to be relatively uncommon. 3 of 18 cats had metastasis. And by immunohistochemistry, all the tumors expressed HepAR1, and there were none with more than 5% cytokeratin 19. So cat tumors are different than dogs. It's my impression that cat tumors met a little more often than the dog tumors. Here are 2 cats with hepatocellular carcinoma, this one being a little bit more developed. This is another example. These images come from this tumor, and you can see, again, these sort of irregular trabeculae and some pleomorphic hepatocytes. What I liked about this one is it was all through the liver, I guess this is the lung, all through the lung. So there was widespread metastasis from this tumor. And then when we looked at it by H&E, you can see the hepatocyte islands in the pulmonary parenchyma. And then these are HepAR stains showing this, and this is a hepatic lymph node, so there was mets, again, like the bat, to the hepatic lymph node and to the lung, but they're all HepAR positive. And this is an animal that died because of its metastasis. So cats can do that. I just have yet to see a dog that has done that. And that brings us to the lemurs, which I'll be speaking about briefly. There is metastasis is relatively common in these guys. 6 of 15. These guys also accumulate iron in their liver, and we tried, as we mentioned earlier, to demonstrate a correlation between iron levels and tumor burden. There was no correlation, so we considered iron. I squeezed as hard as I could to find a hepatovirus in these guys. I found a hepatovirus in a slow, no, I didn't either. I found a parvovirus in a slow loris that had a tumor, but we couldn't find anything in these guys. And these tumors get to be lobular, they're bad actors. Here's the lung filled with metastasis. And here are malignant hepatocytes scattered all through the small and large vasculature of the liver. So lemurs, I don't know how many lemurs you'll see in your practice. We're down the road from the Duke Primate Center, which is all lemurs. So we have access to, I think, the largest lemur population in the U.S. So I think we have the stranglehold on lemur diseases. But there are a lot of lemurs in zoos, and people like lemurs, so you'll see them. So at the moment, we can't correlate it with any of the human viruses or with iron or with any other known. We've looked for aflatoxin in the feed, can't find it. And then we've done some immunohistochemistry, and they are HepBar positive. And some of these look like they're cytokeratin 7 positive. There is a pathologist who was a French pathologist who came to the U.S., who went back to France, who's now in Perth, who keeps promising me she's going to write up her project, which was the full immunohistochemical characterization of the tumors in the lemurs. And we will await publication of that paper. Actually, we await seeing a draft of that paper, but that's coming. Hepatoblastomas, they are not very common. There's two types. There is a fetal and an embryonic form. You can find those in foals, and these two images came from slides that were given to me by Dorothy Beansley and Guelph, who very generously supplied the slides, and I promised to give her bottles and bottles of red wine, which I have not made good on, but I will at some point in time. And then these are all HepBar positive as well. And actually, some of them are HepBar positive, some of them are not. We'll just leave it at that. Oh, I'm sorry. I'm wrong. This is alpha-fetoprotein. And the more mature forms stain with alpha-fetoprotein. Some of them stain with HepBar, some of them don't. And then this is a typical hepatoblastoma in a mouse. They usually arise within an hepatocellular carcinoma. And Dr. Malarkey and I have had many a frank exchange of views, often in public, about whether you count that as two tumors or whether you count that as one tumor when you're trying to do a carcinogenicity assessment. And we've argued about it for so many times that I forget which side of the argument I was on. But whatever side he's on, I'm on the opposite side for the occasion. I think that some of these have been reported in the literature in cats and dogs. I think they're actually carcinoids in the literature rather than hepatoblastomas. I swear I saw one hepatoblastoma in a dog, and then the block disappeared and the slide was gone, and so I've got no proof. But they're not very common in any event. So now I want to talk about something that's perhaps a little more controversial, and that is cholangiocellular adenoma. They're purportedly most common in cats, and they're ducts and cysts lined by well-differentiated biliary epithelium, and cystic variants are called biliary cyst adenomas. I wrote that in the WHO fascicle. I wrote that in the last mutant book, and I'm sure I've written someplace else before. I'm not so sure about this anymore, and I'll explain to you why that is. If you look at the human literature, they are very dismissive of the notion of cholangiocellular adenoma. They think there are very few that are true. They think there are regions in the subcapsular area that are actually hypoxia-driven metaplasia into ducts, and they have some immunohistochemical markers to back that up. That work came from the AFIP. And so I'm drinking the Kool-Aid. I think that's probably the case. So occasionally you'll see these small white nodules that have very small and regular cystic spaces lined with biliary epithelium that's either cuboidal to flattened. So I think they exist. I just think they're very uncommon. These big cystic things that I see, I believe, are developmental anomalies that arise from abnormal development of what's called a ductal plate. And embryologically, initially in the liver, you just have a connective tissue core with just a portal vein in there, and then hepatoblasts around it. And then over time, that inner row of hepatoblasts up against the connective tissue turns into the incipient bile ducts. And most of them undergo apoptosis, but a couple stay and get incorporated into the connective tissue. And then eventually the hepatic artery grows up, and then you have the mature portal tract as embryogenesis progresses. Cats frequently have disturbed development. You know, they always have those 2 bile ducts or 2.5 bile ducts. The biliary tree doesn't develop as well as it might. And I think you get these proliferations, and I'll show you, of larger irregularly shaped bile ducts, and there are phenotypes that are secretory, so that when you're a kitten, you have this tiny little white spot, and as you grow older, they fill with fluid until they become larger masses like this. So here's an example of, there's multiple of this in this cat's liver. You see these irregular spaces, and there's hepatocytes in between. So hypothetically, if you had a bile ducts that are just growing out, they should grow out and push away the hepatocytes. But if you got hepatocytes within them, within those spaces, I think these cystic things arose within the hepatic parenchyma, and they're just expanding over time. The other thing is a fair number of particularly Persian cats that have these cystic abnormalities have cysts in the kidney. So it's a different talk for a different time. And Dr. Williams has sat through it so many times now, he won't let me talk about congenital developmental orders of the biliary tree. The slides that I would show would be a cat with cysts in his kidney, and I say, how many people think this is a renal cyst adenoma? And you all say, no, it's polycystic disease in the kidney. And then I show the cat's liver that has multiple cysts in it, and I say, how could you call this biliary cyst adenoma if he's got polycystic disease in his kidney? You have no choice. You are compelled to acknowledge that it must be polycystic disease in the liver and polycystic disease in the kidney. And they tend to have the same mutation in the Persian cats. It falls apart because some animals don't have cysts in the kidney at the same time. And the net impact is nothing, because they're both benign biliary proliferations, and excision is curative as long as the whole liver isn't affected. And so the distinction, as they say, is academic. But since I am an academic, I like to make the 20-minute points about the distinction. So here's an example of congenital hepatic fibrosis in a cat with these multiple, and dogs get this too, multiple irregular distended biliary spaces. And you can envision these things filling with fluid, and they become the polycystic lesions that we mistake for biliary cyst adenomas. Except in this case, it's the kidney. But that's what it looks like in the liver too. All right, so biliary malignancy, Colangelo or biliary carcinoma, they tend to be single or multinodular masses. The key is they're firm, umbilicated, and they tend to be white. If you can squish it, it's more likely to be hepatocellular. If you can't squish it, then it's more likely to be biliary, assuming it's not metastasis. And then typically you see ducts and acini lined by poorly differentiated cuboidal biliary epithelium. Mucin, we mentioned before. Mitoses are much more common, and metastasis is very common with this tumor. Both dogs and cats, and in the literature, 10 of 10 dogs developed metastasis, 25 of 25 cats develop metastasis. That's a pretty good rate of metastasis. And this umbilication, raised, firm, white, umbilicated lesions scattered throughout the liver, it's going to be some kind of carcinoma. And if you haven't got pancreatic carcinoma or intestinal carcinoma, it's most likely going to be biliary carcinoma. The cut surface shows these things are scattered all through the liver. There's an area of central necrosis, which gives rise to that central umbilication. This is my father's cat. It was an odious cat. And the only good thing that cat ever did is when it died, it had biliary carcinoma that was florid. And although I don't post my own animals, I had no trouble having his cat posted. And so you can see these pleomorphic biliary epithelial cells surrounded by abundant fibrostroma. And then here's a larger duct with areas of necrosis inside of the stroma once again. And in full disclosure, I didn't post a cat, I had somebody else post a cat. But a really nice example of biliary carcinoma. If we look immunohistochemically, these guys are all cytokeratin positive. Cytokeratin 7 is what they used, I believe. And also MUC1 positive. MUC1 is a mucin, and they're all negative for NSE. And yesterday at the JPC, we were mentioning that proliferated bile ducts often develop some neuroendocrine features, and they can stain with some neuroendocrine markers, but at least in the cat, it seems not to be NSE. So here's again the panel from the von Sprundel paper. Here's the cytokeratin 19, they're all positive. Here's the MUC1, they're all positive. Here's the typical acinar formation. And then here's the Hep bars, the normal hepatocytes in the tumor are all negative. This is the case contributed by one of our former residents, Jeremy Tobias. This is a gallbladder, which is thickened and has this polypoid adenoma growing within it. I don't see that very often in dogs. Apparently it happens in cattle more often. So we can see gallbladder adenoma, which I think is what this is, gallbladder carcinoma, which is a much more aggressive tumor, but still biliary epithelium. So it's essentially cholangiocarcinoma, just in a different site. You may see carcinoids. We saw one yesterday. And you may see mesenchymal tumors. And then you may say, show me a mesenchymal tumor in the gallbladder. And I say, okay. And Dr. Fliss, who was yet to give her presentation today, contributed these images. And so here's a gallbladder with a mass projecting from the mucosa. And I thought, oh, good, another biliary adenoma. But you can see there's little islands of biliary epithelium here, but the mass lies deeper, and it's fomentin positive and smooth muscle actin positive. So what's the stain I didn't do? What's the stain I forgot to do? If it was an intestinal mass and I said it's smooth muscle actin positive and fomentin positive, you would say, yeah, could be a GIST. And I never did that stain. I think Amy's the one who forgot to do that. So when we get home, we'll put a C-kit on it and see if it might be a GIST. That's the first one of these I've ever seen. Okay, carcinoids. They are neuroendocrine tumors of the liver, biliary epithelium, gallbladder epithelium, any place they can arise. Presumably there are those cells scattered throughout. Just like they are in the GI tract. Dogs and cats get them. They're uncommon, but we certainly see them in the course of a year. I think they have a high rate of metastasis, and that's why I picked this one, because we can see that there's a tumor scattered all through the liver, which I think is intra-organ metastasis, but they go to other places as well. They're often chromogranin A and NSE positive. And in cats, you can be confused with cytokeratin positive, so-called small cell carcinoma, but I think for the most part, they're all carcinoids. And the carcinoids can have this sort of ribbon pattern here. They can have a more solid pattern, and they still have that fine fibrovascular stroma dividing them up. And you can see this aggressive growth pattern. These cells are just chewing in through the hepatocytes. So they're pretty bad actors. They're not very common. I don't think there's any cure for these things. And then this is a dog carcinoid that was from the von Sprindel stuff. And so they stain this so the cytokeratin negative. And unfortunately, I didn't label these, so I don't know what these other stains are. So they stain with some things and not with others, but I guess they stain with synaptophysin. And then so there's a bunch of miscellaneous tumors. There are apocryphal stellate cell tumors. I'll show you one picture that I lifted from an STP publication. Hemangiosarcoma, fibrosarcoma, osteosarcoma, leiomyosarcoma, but you got to do a very careful job to make sure that they're not metastasis, and myelolipoma. So here's the stellate, the unattributed stellate tumor slides, and I think this is from the STP, proliferative and non-proliferative lesions of the liver. That's available online. We looked at what tumor yesterday that the diagnosis was considered. Here you notice the case that we had yesterday had some mucoid and some myxomatous degeneration, and I don't see that here. These all look like sort of clear cells, but a little bit more solid. So apparently you can see them in rodents, and I think I'm still in quest of one in a dog or a cat. Hemangiosarcoma looks like hemangiosarcoma. You just have to prove that it's not a metastasis, and almost all of them are. Oh, one thing to keep in mind is this this lesion, and this is another thing that Dr. Mutant had to tell me. And we had a corgi that had this liver, and so we all knew what it was. It was hemangiosarcoma. And you will find, as you go through the board preparation process, there's about a 3 or 4 year period of the veterinary literature, and you are an authority on that 4-year period. And there was a paper from 1982, during the period with which Dr. Meaton was an authority on the literature, And he said, oh, that's a corgi. That's telangiectasis. I was like, I never heard of that. And I'm the liver expert. And he said, well, why don't you go look? And there was a paper about telangiectasis in the kidney, around the kidney, and in the liver. And I think it's only Pembroke corgis. And this dog had hemangiomas in his kidney and in his liver. And we've seen one or two since. And we had a resident who's since gone on to NIH, who was a corgi owner. So she's always helped me fix that in my head. So if it's a corgi and you see this and you want to get the Zebra Diagnosis Award for the week, keep in mind telangiectasis syndrome in the corgis. Leiomyosarcoma looks like myosarcoma anyplace else. It just happens to be in the liver. I'm not aware of any other tumor that we found, so we think it was primary in the liver. Myelolipoma, much more common in cats. This is a myelolipoma in a dog. So there's a fatty infiltrate along with a myeloid population. So it's a myelolipoma. You see them in the adrenals more often. You don't see them in the liver as often. You see them in the spleen. And you see them in cats so much in dogs. You see them in big cats. But this is actually this has a bit of bone. So this guy had bone, fat, and mostly granulocytic cell series in his liver. You don't see those very often. And this is a great one. This is hepatic splenosis. Anybody heard of hepatic splenosis? Well, I hadn't heard of hepatic splenosis, and a friend from Australia, who's really South African, sent me these pictures to consult as the liver authority. And he said, I don't know, what do you think about this, John? He said, I think it might be hepatic splenosis. And I thought, I don't know what hepatic splenosis is. So I went and looked it up, and then I said, oh yeah, it is. So I said, yeah, John, it is hepatic splenosis, confirming my authority on liver diseases. And then I got him to send me some pictures. It's the same picture that's in Mutant's book, because it's the only one I have. But there are a couple of pubs. Ohio State published one years ago, and there's been another one in the literature. I can't think exactly where. But what's cool about this is most of these dogs have had splenic surgery, and you drool bits of spleen into the portal vein. So instead of making little splenic islands in the omentum, the little spleen bits run down the portal vein, set up shop in the liver, and they expand. And so I don't know if I have the histo. I don't. So they're mostly blood with sometimes they have smooth muscle trabeculae, and then they have a little bit of red pulp and a little bit of white pulp. So it's really kind of a cool lesion, and you may encounter it. It's like you only see what you know, so it's good to know about this. And then the take-home message, of course, is almost all the lumps in the liver are metastasis. So this is an intestinal carcinoma mets. Again, multiple, firm, umbilicated, white. It's not biliary carcinoma. It's a met. Could be pancreatic. There's a lot of things it could be, but remember that most of the lumps in the liver are going to be metastasis. Hematopoietic neoplasia. You see masses of lymphocytes in the liver. And the very late stages, the lymphoma will march down the sinusoids. And show you differential here would be, how do I tell lymphocytic cholangitis from lymphoma? And sometimes it can be a challenge. Typically, the biliary epithelium is just sitting there looking happy as Larry with a lymphoma, but there's damage and proliferation with lymphocytic cholangitis, so that's one of their clues. The one exception to lymphoma, which typically invades the liver and makes it uniformly enlarged in all species except for the horse. And horses tend to get a nodular lymphoma involvement in their liver. So, primary neoplasia of the liver is uncommon in dogs and cats. Metastatic lesions are much more common in the liver. Metastasis from hepatocellular carcinoma is generally uncommon in dogs and common in cats, but happens in about half of the lemur livers. So keep that in mind when you're doing your lemur work. And metastasis from cholangiocellular carcinoma is very common, and new markers associated with prognosis are being developed. Thank you very much.